Hello, my name is Kate Michelson, and I'm faculty at the Center for Mental Health Policy and the Law, and I will be moderating the webinar for today, which is the final in our series on hot topics in mental health and the law, civil commitment. And today we will be doing a panel discussion on the civil commitment hot topic series. A couple of logistics first. So this series is brought to you by the Center for Mental Health Policy and the Law, which is housed within the University of Washington Department of Psychiatry and Behavioral Sciences in the University of Washington School of Medicine. The center's mission is to address the most urgent issues arising at the interface of mental health and the law in order to help justice-involved people with mental illness lead full and productive lives. You can learn more on our website. As a reminder, this is the last session in an 8-session series on the topic of civil commitment. You can find the recordings for all of the previous sessions on our website. As the moderator of today's panel discussion, I have the distinct honor of introducing our panel, which includes representatives from each of the 7 preceding talks in this series. I will do that in a minute, but first a couple of logistical notes. First, a note on recordings and continuing education. The recording of this session will be made available on our website within 1 week. We will email attendees with the link. Continuing education is only available for attendees who attend the Zoom session live, not for those who are watching the recording. Certificates of attendance will be available for attendees who indicated interest. You'll receive an email from the center with additional details. Continuing education is available for UW faculty and staff only. You received an email from the center with instructions and will need to sign in via text by 2 today. For non-UW learners, we will track attendance via Zoom. You do not need to log in or update your name in Zoom, as attendance is tracked with your unique Zoom link. Dr. Candelas has disclosed the following relationship, including stock or stock options, excluding diversified mutual funds from Merck, Pfizer, and Cigna. The rest of the speakers have no financial relationships with an ineligible company relevant to this presentation to disclose. None of the planners have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And all financial relationships have been mitigated. You may enter questions into the chat. Center staff will be responding to technical or logistical questions in the chat. Today, topical questions have been carefully selected from questions that were posed during the preceding sessions. And I will be working through a list of some of the most frequently asked questions. It is possible that we may have time for some real-time questions at the very end, but we will have to see, and we'll certainly bank questions as we are thinking about future potential talks through our center. Final logistics: the opinions expressed herein are the views of the speakers and do not reflect an official position of the center or the UW. No official support or endorsement of the opinions described in this presentation from the center or the UW is intended or should be inferred. Automated captions are available in the meeting controls toolbar. Click the Show Captions icon. Please complete the evaluation poll at the end of this session. We really do evaluate your feedback, and I believe Selena will push that into the chat towards the end. All attendees will also receive an evaluation survey via email about the webinar series as a whole. Even if you've only attended 1 or 2 sessions, we really appreciate your feedback. You can just give feedback on the sessions you attended and your experience, and that is valuable as we think about future series and talks. So today, our learning objectives are that by the end, participants will be able to identify the diverse perspectives on civil commitment presented throughout the series, explore ongoing community needs concerning civil commitment, crisis care, and evidence-based practice across the behavioral health continuum. So to introduce our panelists today, Dr. Candelas is a forensically trained psychiatrist who has contributed to professional ethics through organizational statements, reports, and academic papers, as well as chaired the ethics committees with various professional organizations. His talk was on civil commitment through the ethics lens, how we got here. Senator Dhingra is a deputy majority leader of the Washington State Senate. She brings 2 decades of experience as a prosecutor and behavioral health expert to her work in the Senate, including helping to transform the state behavioral health system and expanding 988. Her session was on policy perspectives on Washington's continuum of care for severe mental illness. Next, we have Shadow Jones, who advises, Ms. Jones advises on key policy considerations, collaborates with legislative partners, and provides legal counsel to advocate for the improvement of state and federal laws and systems of care to benefit individuals with severe mental illness with the Treatment Advocacy Center. And she started off our series with the talk Civil Commitment 101, Overview of History and Current Practices. Dr. Kopelovich is a forensically trained clinical psychologist in the Department of Psychiatry and Behavioral Sciences at the UW and a core faculty member at the center. She holds the first professorship of cognitive behavioral therapy for psychosis and has principal and co-investigator status on federal and state-funded initiatives related to evidence-based mental health practices. Ms. McCready Santos is co-president of the Washington Association of Designated Crisis Responders and has been a designated crisis responder in Clark County for 8 years. Ms. Pippin is a co-president of the Washington Association of Designated Crisis Responders and the program manager of crisis services in Central Washington. Don and Laura provided important information about the DCR process during their session entitled Designated Crisis Responders and the Involuntary Treatment Act in Washington State. Dr. Silver is a child and adolescent and forensically trained psychiatrist whose work includes workers' compensation, disability claims, fitness for duty evaluations, tort claims, and competency evaluations. His session was Navigating Juvenile Involuntary Commitment in Washington State. And finally, we have Ms. Van Tosh, who is a patient turned activist. She founded the Mental Health Policy Roundtable, as well as writing extensively about peer-operated behavioral health care services and homelessness, and working inside 3 state hospitals. Together with Carolyn Ponzoa and Karen Schild, she presented lived experiences with civil commitment. So please join me in welcoming all our panelists. We are so fortunate to be able to learn from their experience and expertise on this topic and their diverse perspectives. And just a little information for those who are joining us. I will be initially directing each question at a couple of the panelists, but then opening it up for other panelists to chime in as they are interested. I'm going to stop sharing my screen now and shift to my questions. All right, give me 1 second. So my first question I want to direct to Dr. Kopelovich and Ms. Van Tosh. And that is, I think this question came up several times in different versions, but several of the speakers in the series have highlighted the importance of care continuums and coordination in our mental health system. When we think about someone in or nearing crisis, or someone who has a history of multiple past involuntary treatments, what's the existing evidence for alternatives to involuntary commitment? And thinking here about things like peer specialists or bridgers, clubhouses, or crisis units. And Dr. Kopelovich, I think I'm going to direct this to you first.
Sure. Thank you. Thank you, Dr. Michelson, for hosting this panel. And thank you to Selena Adler for the tremendous back-end support you've provided to the series. One of the messages that I tried to convey in my session is this idea that we have to think of civil commitment as the extreme end of the care continuum. And if we want to shrink the utilization of civil commitment, we can't do that unless we expand the other parts of the care continuum. So thinking about upstream alternatives to civil commitment that need to be well resourced. We also need to think about continuity of care across this continuum. And so everybody across the care continuum, regardless of setting or level of care, needs to be adherent to national treatment guidelines. I'll focus on programs rather than specific interventions. So the kinds of upstream programs that we want to see to be able to reduce the use of civil commitment would be diversion and reentry services, right? These are coordinated programs to help people with behavioral health issues avoid jail and hospital visits. That is both upstream, but it may also be downstream when folks already have criminal justice and multiple hospitalizations. Same goes for programs of assertive community treatment. Or PACT, as we call it in our state, ACT, as it's called in other states, as well as forensic assertive community treatment. These are specialty care teams that are designed to provide intensive multidisciplinary care in the community to individuals who have high contact with both mental health, psychiatric, and criminal justice settings. And we've got a ton of research already out there on these programs, some of which have been spearheaded by my colleague at University of Washington, Maria Monroe DeVita, colleagues at University of North Carolina, that give us a roadmap for how many of these kinds of programs do we need to address the needs of the population in primarily large urban centers, but that data can be extrapolated for rural settings as well. And we see again and again in systematic reviews on assertive community treatment that they are effective at reducing hospitalizations, among people with serious mental illness. Mobile crisis teams or co-response models, which are growing both in popularity and in funding. These are teams that include a mental health professional and or peer support specialists, as well as law enforcement to provide interventions at the point of crisis. Oftentimes we see that these crises can be resolved in the community rather than needing to escalate to a detention in jail or hospital. Peer and recovery-oriented crisis services, which I will trust Laura Vantosh is going to be speaking to as well. In terms of the evidence base on these models seem to be reducing emergency room visits, involuntary hospitalizations, improving patient satisfaction, which is absolutely crucial because we need to keep people's trust and faith in the mental health system. And they also really support recovery-oriented care. And then while not necessarily a clinical program, I will put in a plug for Housing First and addressing social determinants of health. Obviously, that's a broad system level need, but these are long-term strategies that where there's robust evidence at this point that suggests that they can reduce hospitalizations, justice involvement, and improve symptom stability.
Thank you, Dr. Kapelovich. Ms. Vantosh?
Yes, I want to just echo a bit what Sarah had talked about, and just want to thank you very much, Sarah, because you really cut across many areas of the continuum with your remarks, and I completely agree. I do want to just say that the evidence is actually pretty pervasive, and this isn't probably the best place to list all of the citations and research per se, but let me just provide you with a little bit of information that I pulled together. First of all, nothing can really be said if it were not for SAMHSA, the Substance Abuse Mental Health Services Administration, and really their leadership over more than 20 years in developing opportunities to identify, expand, and research evidence-based services, originally not considered evidence-based at all, and now very much a part of our systems of care. Unfortunately, not all of the research is really, due to scrubbing of websites and other resources, especially technical assistance centers. Much of the research now is a little bit hard to find, but typically people are doing searches and identifying recent research as well as historical. I found an article that was written in June of 2015, that's 20 years ago, 10 years ago, by Laisha Ostrow and Bevan Croft, and they came together and developed a really important open forum piece for psychiatric services about peer respite and crisis care, originally kind of considered more on the respite side of things than crisis services. But that really helped. It was only a few pages, by the way, and I can get the citation to the university if you want to share that information out. But that really began to articulate some of the research that had been conducted early on. I also want to point out, in terms of peer respites, Washington State has 3 peer-run peer respites. One I think has got also a family focus. They're doing pretty well. I've been able to find out that they're kind of covering, in essence, basically 3 quadrants of our state. Certainly not enough of them, but they are voluntary short-term residential programs. They act as a dynamic center where peers can volunteer, connect with others, seek and receive informal and clinical kind of services by peers that have been trained in the behavioral health care system. Nationally, by the way, and I just want to point out the Promise Resource Network in North Carolina, kind of great. It's great to hear they also are leaders, and I do know that in the terms of the ACT model. But North Carolina has an outstanding statewide organization called Promise Resource Center. They were identified as an innovative service system practically by the Bazelon Center for Mental Health Law. And they have a number of peer respites around their state. They also have done research with other organizations to expand on crisis supports and crisis consumer and peer engagement with delivery of crisis care services. Also, in terms of peer respite, Live and Learn Incorporated is a peer-run research organization. They're doing incredible work on peer respites. They have their own webpage, own kind of inventory of peer respites throughout the United States. Also, the Bazelon Center for Mental Health Law created a huge compendium, basically, of crisis services run by peers, and their latest publication is called When There's a Crisis, Call a Peer: How People with Lived Experience Make Mental Health Crisis Services More Effective, and that was published in 2024. So I just want to kind of laying out a few of the options that are out there. One I just don't want to forget to mention, sometimes doesn't always get included in these discussions, is the role of clubhouses. We have a clubhouse network really being established as we speak in Washington State, with Northwest Clubhouse Association doing a fabulous job creating these models that are community-based and extraordinarily important for people to avoid hospitalization and receive good peer-driven services.
Thank you so much, Ms.
Sure.
Antosh and Dr. Kapelovich, for that eloquent summary of the continuum and available resources. Do any of the other panelists want to chime in on the question on the continuum? Not seeing any hands. I will move on to the next question. So we have had over the series a lot of questions on assisted outpatient treatments. And so I want to direct this question both at Ms. Pippin and Senator Dingra. What is the current state of AOT practice in Washington State, including resources around treatment and monitoring and enforcement, if someone's not adherent or decompensating? And what are some of the next steps, thinking ahead in terms of the deployment in our state? So, Ms. Pippin, do you want to start with this question?
Yeah, thank you very much. So right now, there's 6 counties in the state of Washington that use an AOT model, assisted outpatient treatment. And then it's been picked up kind of slowly depending on the resources in the county, the structure of the agencies to take on an assisted outpatient treatment model. So this model lets practitioners, providers, directors, ED physicians, release planners from corrections facilities to file these petitions. And then an affidavit goes with them, and we file them to the court. And again, it goes into a hearing, and they can be contentioned or not. Once they go through, they're monitored by the court. They're set up on a time schedule for up to 18 months of assisted outpatient treatment. They go back in front of a judge, depending on what the commissioner judge determines the need is. They'll have case managers with assisted outpatient treatment that helps provide the supports to get to their treatment, their therapist, their med management, also to start helping put factors in place for living, for their goals, getting jobs, going to school, getting their DSHS stuff aligned, getting licenses. So it sets a goal to help them be more in charge of their own well-being, their own individual state, and what they're wanting. With the AOT, when a person decompensates or may need that hospitalization or is not meeting the criteria of what this order is, there can be a revocation of that order, which is very similar to an LRA order that comes out of the court. They have 90 or 180 days. So it looks very similar to that. The assisted outpatient treatment would go in, write up the petition, say what they are not engaging in, whether it's the medication management, the therapy, not being able to stay out of an ED, stay away from the substances, or are not engaging. Then that revocation looks similar. They would go to an inpatient unit, stabilize, and then come back and continue with their AOT contract. Let's see. So I think I can let Senator Dingra take over from here.
Senator, do you have additional thoughts on current resources for AOT and next steps?
Yes, absolutely. You know, we had passed the AOT bill in 2022, so it's been 3 years. And the intent really was to make sure that we are providing a level of care that's below hospitalization, right? Because we don't want people to be hospitalized against their will. So this was really an effort to make sure we had this option available in the state of Washington. I will say, I understand it's only been 3 years, but I was really hoping that we would be a lot more, further along in making sure AOT was available to everyone all across the state. So some of the barriers that I have been informed of is really the funding model to make sure that each area has the resources and the agencies and the workforce to be able to implement this program. The other thing we did with AOT, which was very different than what we do with inpatient civil commitment, is the list of individuals who can petition for this order. As everyone here knows, in Washington, we are an outlier in having the DCRs be the only ones that can do inpatient civil commitment. And so AOT was really an attempt to see what would a model that has DCRs but does add additional individuals do. The point was to make it more accessible to others. So there's a lot more work to be done. I do want to make sure that as a state, this is a resource that is available to everyone, no matter where you live.
Senator Dingra, can I add one more thing that's kind of important? When someone is on a petition and gets committed, they lose their gun rights for life. So again, that part was not put out there by me, and I apologize.
It's not for life. They
It says
lose
permanently, so.
unless restored by a court.
Okay.
And so there's federal laws around this as well as state laws, but it can be restored by a court order.
Thank you, Senator.
Great, thank you so much. And so it sounds like, continuing money, I think it was the bottom line for your talk originally, Senator Dingra, and it sounds like that continues to be the bottom line for AOT as well. Any of the other panelists want to chime in on this topic of AOTs? Ms. Van Tosh, please.
Yes, just briefly, I didn't realize that it was, 6 counties, and I guess the rolling out of a program like this is very, very challenging. I'd be very interested at some point learning what the assertive community treatment team model, how that's rolling out, if there are more sites than AOT. And I think ultimately we need to look at a comparison of these two services, actually see what's clinically appropriate, how people are faring that way, as well as the satisfaction piece, which I agree, as Sarah mentioned, is a really good thing to look at as well. So just a Washington State sort of focus question and comment. Thank you.
Okay, so you're anticipating a question that I can maybe move up the line, which was around metrics. Did anyone else have anything they wanted to say first about AOT?
I'll just add, given all the comments in chat, there are implementation issues, especially around the burden of proof, what a revocation looks like, who's utilizing it. So it is absolutely not a perfect system, and it is not being consistently implemented across the state. So someone's experience in AOT in one county is going to be very different than someone else's experience in another county. And those are the things that we are continuing to look at legislatively to see how we can do best practices. I will say that we do have a work group that we did this session on Involuntary Treatment Act. And so we will have experts coming together to take a look at a civil commitment, and hopefully those recommendations will have some improvements that we can do to our AOT system as well.
Thank you, Senator. Let's see if I have any other hands raised. So I am going to go to the follow-up question on data collection metrics. I know this came up especially during our policy talk, but it's come up in other talks as well. And this is going to be directed again at Senator Dingra as well as at Ms. McCready-Santos. Is there any, what kind of data or metrics are we looking at to determine the impact of the various policies around involuntary commitment, and thinking about kind of both current practices like current DCR referrals, as we shift practices like trying to encourage 911 handoffs to 988, or the transition to the 120-hour holds, for example. Senator Dingra, do you mind taking that first?
Not at all. I always love talking about data. I will say when it comes to our civil commitment or our behavioral health system, we have data collection points at many different points, and we really have to have a much more coordinated system of kind of putting it together. And, when this question came up, I was really reflecting that it might be time for us to actually ask our state auditor to do an audit of the system. Because there is just so much going on right now. We've made so many changes over the years. We do have data that's being collected specifically on the 988, 911 component. We do have co-location in a couple of areas. And the initial data we had coming in actually shows that there are a lot of 911 calls that are referred to 988 as being a much more appropriate response to that 911 call. And this is still kind of new, so we are getting data on a yearly basis. We are also one of the states that has over 95% call pickup within the state, because as we know, overflow calls can go to another state, and then we are, far ahead of where the metrics need to be on those things. The DCR referrals, we do collect annual data on it, as well as, unfortunately, how many people are still being boarded in our hospitals. This is the single bed certification that we deal with in our state on a daily basis, which means we actually don't have sufficient mental health beds in our state. And so our hospitals utilize a single bed certification, which really is not any way to humanely treat individuals struggling with severe mental illness. And that data is, again, collected on a regular basis. I will say Joel's Law, unfortunately, is not being utilized. Again, there is inconsistency around how it's being implemented across the state, courts' understanding of it, and then the availability of family members to actually petition the courts for this. And this is where I think the AOT referrals data needs to combine with Joel's Law's petition and see if there is any overlap. The other thing I will mention is DSHS keeps a lot of data on the forensic side of patients. And what I have asked over and over again is that we actually need to take a look at our forensic data and combine it with our civil data to see where the overlap is. Because we should not have civil patients that end up in our forensic population. And so some of the work that we have done, and I know that any time between 30 to 40% of our forensic patients are the ones that have circulated through the system over and over again. And so to me, it's very critical that when we take a look at that data, that we try to figure out how do we take this 30 to 40% of individuals who are circling through the system? Because to me, that means we do not have a program that's meeting their needs. And I do think as a state, we should be really focusing on those individuals and try to do something that's more individualized around them, because they are utilizing services that are extremely intense and not necessarily set up to provide long-term care. So there's a lot of data. A lot of this data actually does drive legislation. And this is also where, when we take a look at where we're putting dollars, we try to be as data-driven as possible. But I will say that given the financial situation of our state this year, they'll continue next year, and what is happening at the federal level with Medicaid reimbursements and access to healthcare in general, it is going to become more and more challenging on how we navigate these resources. And frankly, who gets these resources? Because we clearly don't have the sufficient number of resources to help everyone. We want to get to the point where we are, but unfortunately this year and next year is going to be extremely challenging.
So it sounds like a tight couple of years, and also maybe a little bit of siloing of some of the data. Ms. McCready-Santos, do you have anything you want to add about data collection from your perspective, kind of on the ground?
My sort of perspective is we've tried to access some of the data regarding ITA commitments and involuntary holds, and that data is not very easy or user-friendly to access. I think there's not a ton of transparency by the state, and so that's been actually a really frustrating aspect for me as an advocacy group for the Washington State DCRs. I feel like that is something that we could all be using and utilizing to kind of guide legislation that we're involved in as well. And it's been something that's been incredibly difficult to access. So any transparency that can be added to this process, I think would be really helpful. Yeah, if, in the future, I think that would be the one area that I would really like to see some improvement.
Thank you. I see a couple of hands before, I'm gonna go to Ms. Jones first. I know that the Treatment Advocacy Center does some looking at data like this at a national level, so I'm very curious to hear your perspective.
My perspective is a summary of the two previous answers. We see that nationally, there's a real lack of data collection, lack of transparency, but there are states that do collect some data points, but they might be siloed or they might not be utilized. But the attention to the need for data and using data to drive policy has picked up in this area in civil commitment over the last few sessions. So we're now seeing more states put forth legislative measures that will mandate data collection reporting to the legislature. Whether or not those reports are also posted publicly is another piece. But I agree that transparency is very critical in this area for everyone to be able to work together and understand where the gaps are, understand where the needs are, and to be able to provide the best assistance to the people who are being served by the system.
Thank you. And Dr. Candelas?
Yeah, what we run into in Washington, D.C. is the difficulty of distinguishing people by whether they're civil or forensic. So what we're trying to do is to figure out what metrics are useful across those categories, because whether someone ends up criminalized determines their entire trajectory. So if there's some way to measure violence, if there's some way to measure adherence, return to hospitalization, rearrest, there's got to be a better way to cut down the siloing. And that's a data analysis matter. The civil forensic distinction, I think, is one that it persists in a pernicious way, because the system works to move people where the system thinks they're most conveniently managed. And that could be a judicial decision, a non-clinical decision. So if I could emphasize that distinction is not helpful. What's helpful is, sequential intercept type of outcomes, rather than distinguishing the legal category for the patient.
Certainly, we see a lot of overlap, I think, in our populations between our civil and forensic populations as well. Thank you so much. Anyone else? All right. So another thing that we've had another topic we've had several questions on over the course of the series was on psychiatric advance directive. And I'm going to direct this at Ms. Van Tosh and Ms. Pippin initially. And I'm curious, what is your experience using psychiatric advance directives or mental health advance directives? And is there evidence or anecdotal experience suggesting they can prevent hospitalization or decompensation? And what is your experience with this? So Ms. Van Tosh, if you're willing to take a first stab, that would be great.
Sure. Thank you for asking this question. And I just want to add that I think Senator Dhingra also has a great interest in this issue as well. She's just played we may disagree on particulars, but I really believe overall we have a lot in common. So I just want to thank you, Senator Dhingra, because you make me think about that, because that's the only way we're going to get through this. So I agree with transparency. I agree with the fact that we need to look at the silos. I agree that we're going to have to possibly hurt a little bit in the next couple of terms because of the budget. That may also have to bring us together to come up with some common sense, reasonably costing kinds of services and interventions. And I do believe that the advance directive is one of those possible tools that we can really probably spend a fairly small amount of resources to get an advance directive model on the road. And there is already a work group that's been impaneled. I'm personally not involved with it, but I've seen the membership list, and it's really a huge cross-section of leaders, clinical, peer, all advocates on this panel working hard to develop. Basically, they have two large work groups, one regarding training so people can come up to speed with how to actually use these tools and have some regularity across the board. And the other is to develop a repository for advanced directives, a place where these directives can be held, where people can refine them over time, perhaps, but also through policy, looking at how we can protect privacy, but see the kinds of things that people are asking for, and kind of reshaping our system in a way according to the kinds of things that people say they need in terms of a crisis. I use something like it in Oregon, called a person-delivered plan, a PDP, and it was really something very helpful. The developmental disability world actually has other kinds of tools that I think are replicable across areas, including behavioral health care. This particular plan actually supported me through a couple of crises, but it was not considered a legal document. And the advanced directive can be considered as such. And I think so there's a difference there. Washington State actually has, I think for over 15 years, maybe a fewer number, have an advanced directive piece of legislation that Senator Karen Kaiser brought forward many years ago. And so we've had advanced directives in our system, but it's just not been utilized properly. So there's now been this return to focus on how to bring that up to par. And I think the last bill, I don't know, Senator Dinger, if you were involved, but Senate Bill 5660, which talks about these two work groups that I mentioned and next steps for our state on advanced directives. So I support them as a tool. I think they're helpful. And I believe that we can make some advancement on that and make sure that we have proper training and places like a repository that can be used for future research and development.
Great, thank you. Ms. Pippin, curious about your perspective on advanced directives and also kind of thinking specifically about the DCR role, kind of how and when are DCRs looking for them, considering them?
Yeah, I appreciate the question. So during the DCR investigation, that's one of the questions that we ask, do you have an advanced directive? And if they say yes, then we look for it. But if they don't have it with them, it's not at the hospital or a family member can't bring it, then we have to move forward with the rest of our investigation and our process. If they have it or the hospital we're at has a copy of it, because a lot of the times they'll be at the hospital and you can get a copy of it if they have one. It really depends on the state of the person and whether an inpatient facility will recognize the advanced directive and as an approval for care and treatment needs. And a lot of times the different facilities will not. And then we have to just move forward with the involuntary detention. But we have to try to pay attention with the requests, and we usually put them in our petition. Like if they're allergic to certain medications, or if they've tried medications, or if there's certain ways to be treated or looked at, cultural perspectives, religious perspectives, we try to attend to those and make sure to incorporate those in our petitions so they're getting the right intervention and care they need to get, discharged and back into the community. Yes.
Thank you so much. Dr. Candelas, I see your hand. You have some.
Yeah, I do. I mean, this patient psychiatric advanced directives go back to the Patient Self-Determination Act. I mean, this is Cruzan. There's regulations in CMS, Medicare, Medicaid services that support them. I'm intrigued by Ms. Pippin's statement that the hospitals have that kind of freedom to ignore it. Is that something you can say a bit more about, Laura?
So I can't speak for the facilities. I can only speak as a DCR. And when we're looking for bed placement, if we don't involuntarily detain them, they usually won't take the advance directive. So does that make sense?
It does, because, and again, we have that problem in the East too, because people don't want to take voluntary patients who will come in and then sign out within the hour. So I get that as a policy issue, but there is a lot of support legally for psychiatric advance directives. I think there's still the mystery around it because it's just not the information is not disseminated as well in certain states as it is in Virginia, North Carolina, New York, where there are big programs and research groups like Swanson's and Duke and all that that study these kinds of outcomes. But I do see that as a little bit different because the hospitals here, at my hospital, I don't take voluntary patients because of these problems, unless I'm forced. But it's there is good support. There is good legal support for the advance directive. And this is true medically and psychiatrically. Since I was a student, I mean, 70, 80% of people support advance directives. They just have difficulty sometimes finding people who are good surrogates and are willing to do what they say. Because the tension, the ethical tension is between best interest model and surrogates. So often the decisions will be made as best interest decisions rather than, patient wishes.
Yeah, we have the same trouble with guardianships and power of attorney with our facilities over here. Very, very similar. And again, I can't speak to their policies and processes, but they're allowed to tell me no. So.
Thank you. I think I'm going to move us on to the next question. And that is, I'm going to direct this to you, Senator Dhingra, again, is I know that we got to talk a lot about legislative work that has been going on for the last few years. But there's been some curiosity about kind of planned or, kind of ongoing efforts around changing the rule or the process for involuntary detention, and particularly around altering the DCR process, such as allowing professionals at crisis service centers or physicians to order or request initial detention. I'm curious if there's any ongoing efforts or plans around that.
Thank you. I do get asked this quite a bit. And that was one of the reasons when we did the assisted outpatient treatment bill, is to come up with a list of individuals in addition to the DCRs who could file the petition, because we really wanted to see how that would play out. I will say that this has come up again. People are interested in working on a bill draft that adds the same kinds of individuals that are currently in an AOT petition to our ITA petition. We've heard from a lot of family members that unfortunately our DCRs are so overworked, we simply don't have enough to meet the needs that's out there. And so there are people who are interested in expanding that list. And I think we always have to be careful, right? You want to make sure that you are protecting an individual's rights, that there isn't potential for abuse. This is why Washington went to the DCR model to begin with. But I think people want to kind of come back or maybe move a little bit towards allowing others to file that petition. So I've been approached by numerous people about this. So there might be a bill on this for session. And I think that will be the opportunity for everyone to chime in and see where they think the state of Washington needs to be. But we are an outlier in terms of only requiring DCRs to file the initial petition.
Thank you, Senator. And Dr. Silver, I recall in your talk mentioning that you'd worked in states where there was more of a direct one or two physician petition possible. Would you care to share with us some of the pros and cons of the different systems from your perspective?
Yeah, I think there's a lot of value in comparing and contrasting different states. So my training in medical school and residency was in Missouri, so Washington University in St. Louis. And indeed, yeah, there it was. The initial intention was purely a single physician. He had to fill out a petition, fax it in, so the court was aware. But pure judicial oversight didn't occur until you moved past the 72-hour. I think it was 2 weeks after that, so a 14-day hold. And there are certainly advantages to it. The concept of a continuity of care, which is to say that if as a physician I feel that a patient needs treatment, and by definition the patient would not want to be there, and of course that's when you would have to move to this sort of ITA-like process. As a physician, you're able to simply enact that process and get them better faster. You can treat their psychosis. You can sort of stabilize them if they're suicidal or whatever the acute issue happens to be. With the DCR intermediary in this state, certainly you do have the potential to provide greater respect and a sense of autonomy to patients, because they have the ability to have an outside or a third party weigh in to balance their stated desire to leave the hospital versus the medical opinion that they should stay. But it can cause complications, and those complications being that lack of continuity of care, the prolonged process of trying to get them stabilized. If somebody is acute, acutely suicidal, then there have been instances where an individual attempted suicide, and based upon their behaviors, in the hospital over the course of 2 days or so before they got to the inpatient psychiatric unit. At that point they were voluntary, and they said they wanted to leave, and the DCRs agreed with them, and so they were allowed to leave the hospital. These sorts of things, from a physician's perspective, are concerning, but it's always going to be a matter of balancing, autonomy, individual liberty, and the protection of that liberty and civil rights with this concept of medical intervention, or parents patriae sort of intervention. So there were pros and cons to both systems, and I can appreciate more fully the pros and cons to the differences after having practiced in 2 states.
Thank you, Dr. Silver. Ms. McCready-Santos?
Yeah, I would like to add, I've also worked in 2 different states, Oregon and Washington, and there are differences in the way it's approached. Oregon is a 2-physician hold state, and the patient is first detained, and then they have an involuntary investigator who will come in and do the case afterwards, and it can take them up to 3 days to investigate the case and decide if that hold is valid. And then there's Washington State, where we are coming in and doing a full investigation at the front end, and then being sort of the deciders of what's going to happen. One of the things that I've really found to be difficult for some of the physicians I've worked with in the ED is because they're so busy and they have so many things to worry about in terms of that patient's health, medical care, everything else. They are not always on top of the legal realm of putting somebody on a hold. And I think that can be really hard. So one of the biggest areas that some physicians have trouble with is imminence. And one thing that I have a lot of conversations with some of the physicians that I've worked with is, what does imminence mean? It's not enough just to say this patient is mentally ill, let's put him on a hold, which I do find some physicians want to do that. I'm able to have that conversation about what is imminence legally in our state. And I really do feel like that allows us to sort of protect patient rights. And it really gives us the ability to advocate for the patients and make sure that they're getting appropriate care and not having their civil rights removed without due cause. I also think that by completing this process ahead of time, kind of front-ending it, where we're actually doing a full investigation, we're able to talk with collateral. We're able to talk with family. And actually, it's been very helpful for some of these patients to have that information in the initial petition, because I do feel like that actually helps guide the physicians who are seeing these patients in the inpatient setting when they have that information to help provide, continuity of care for these patients.
Thank you so much. And I think that we are running out of time, so I'm going to share my screen again. Unfortunately, there are so many additional good questions that we have not been able to get to, but we will try to bank those. And actually, I'm having trouble sharing my screen right now. Selena, I don't know if you can share the final 2 slides. Selena, oh, great, thank you so much. So just a reminder, our learning objectives for today were that by the end, participants would be able to identify the diverse perspectives on civil commitment presented through the series and explore ongoing community needs concerning civil commitment, crisis care, and evidence-based practice across the behavioral health care continuum. And, I really appreciate all the panelists joining us today and sharing their perspective. There is so much more we could have gotten to, and I'm sorry we don't have more time today, but this is such a rich topic. As a reminder, we will be sending out an evaluation survey for both this session and a separate email to request feedback on the series as a whole. And please, again, even if you've only been able to attend a couple of sessions or one session even, we do appreciate your feedback on the series sessions you joined. But please join me in thanking all our panelists and all our audience members as well for providing such amazing questions and being so engaged with this series. We really appreciate it. Thank you.